Welcome, and we're delighted that you've chosen to join us on this session about safe obstetric anaesthesia in low middle income countries. What do surgeons need to know? Now, we all know that labour ward and delivery is a team sport, and so we're delighted that you've chosen to join us. We also know that in the safest of labour wards, anaesthetists, obstetricians and midwives work closely together in order to achieve the best outcomes by putting their skills together. And so I'm delighted that we've got a really talented group of obstetric anaesthetists joining us for this session. And we're going to cover key aspects. So we're going to be talking about maternal outcomes, about well-being and analgesia in labour, and also about operative delivery, and then thinking about team working in obstetric emergencies. But I'm delighted that as our first speaker, we have Dr. David Bishop, who is probably needs no introduction to this audience. So he is an obstetric anaesthetist in Pietermaritzburg in South Africa. And he's lead author on the ASOS study, and I'm sure we'll be hearing a lot about that really pioneering work, which involved a lot of researchers across Africa and many people probably joining in today. So he's going to be talking to us about maternal outcomes.
Right, thanks very much, Neil. Yes, as you mentioned, I'm an anaesthetist working at Edendale Hospital in Pietermaritzburg, which is a low and middle income country. And I'm going to be speaking for the next 15 minutes about maternal outcomes. And as we delve into the problem and the numbers, I'll try to focus on what we can do to improve things as we go. Probably the most important things we need to know are that still every year we lose about 300,000 women during childbirth. And secondly, 99% of these deaths occur in low and middle income countries. And I've put Africa up there because that's what I'm going to focus this talk on. But in fact, this talk will apply really to any low middle income country in the world. Now, the United Nations Sustainable Development Goal, this is number 3.1, and it said that the goal is to have the maternal mortality ratio at less than 70 per 100,000 live births by the year 2030. With no country exceeding 140. So that's the goal that they've set for essentially 10 years' time. So how are we doing? Well, on the surface, it would appear that we're making good progress. This is a graph of the falling maternal mortality ratio. And as you can see, it's declined by about 37% between 2000 and 2015. Still over 300,000 deaths in the year 2015, mostly from preventable causes. But as we'll see, the global average doesn't necessarily reflect the low middle income country situation. This map looks at country-specific maternal mortality ratios, and the dark blue are areas with ratios of less than 100, light blue less than 300, and it's the yellow, orange, and red areas where those numbers are very, very high. And as you can see, this is largely an African problem, especially in Central and Northern Africa. Those numbers get very, very high indeed. If we zoom into Africa, here's another map that shows the country-specific maternal mortality ratios. And countries like Chad, South Sudan, Sierra Leone, they have maternal mortality ratios in excess of 1,100, 1,140 in Chad, 1,150 in South Sudan. So these are some of the highest numbers in the world. One of the main drivers in this problem is a lack of resources. And one of the surrogate markers for resources is workforce density. And this is taken from the ASOS study in the Lancet in 2016. And as you can see, where maternal survival is lowest, there are less than one specialist per 100,000 population. And when it gets up to 20 to 40 specialists per 100,000, maternal survival gets much better. And that's the thing that I think we could have known intuitively. In Africa, there are 1.2 billion people, and 95% of them lack access to safe surgery. And so we can see that lack of resources is potentially driving this very, very high maternal mortality ratio. This is a graph that looks at the predicted maternal mortality ratios as it relates to caesarean delivery rate. And you can see that the maternal mortality ratio falls with a rising caesarean delivery rate. And that keeps falling until you get to 19%. At around 20%, you start to lose the benefit of having a higher caesarean delivery rate. So paradoxically, in the high income countries, we're trying to reduce the caesarean delivery rate, while in the low and middle income countries, we need to increase it. And clearly we need to increase it, but we need to do it in parallel with safety and quality improvement programs so that we don't just increase the rate and increase the death rate at the same time. Now in sub-Saharan Africa, the caesarean delivery rate is pretty static, around 3.5%. So it's very, very low, despite an increasing global trend. And what we need when we look into these very high numbers and these high death rates is good data. The problem really is that we're lacking it. One of the best ways to do it is through a confidential inquiry process. And in Africa, the only established confidential inquiry process is in South Africa. And even that inquiry is fairly limited. So there's very little data coming out of national confidential inquiries in these low and middle income country settings. I'm going to look a little bit at some meta-analysis. There's been some good meta-analysis out which combines studies from these various areas to try and give us the numbers we need to generate the signal we need so we can understand the problem better and potentially intervene. The problem currently is that perioperative research and clinical guidance often fails to acknowledge the system level deficits, and therefore it has limited applicability in these low resource settings. And finally, we'll come to prospective outcomes. And this is probably the best way to get data and to understand what's going on in these areas. So this is a cartogram taken from a study by Dutoy et al. In Anaesthesia in 2019. And essentially, this is looking at how much literature do we have on surgical preoperative optimization and where does it come from? And as you can see, in the country that, or the continent that needs it the most, there's almost nothing. This is the latest, and this is much improved over decades before. So in the areas where we're having the most problems and the highest maternal mortality ratios, we've got no country-specific literature, and that's what makes these problems difficult to understand. This is from a meta-analysis by Sobey et al. In Lancet 2019, and this meta-analysis combined studies that looked particularly at maternal and perinatal mortality and complications associated with caesarean section. So this is only the caesarean section deaths that they looked at in low and middle income countries. And in their cohort, more than 50% of nations had a caesarean delivery rate of less than 10%. The mortality rate was 7.6 per 1,000 procedures. And we don't talk about maternal mortality ratios in this population because we're not looking at all deliveries. We're only looking at the caesarean section delivery. And in all deaths, a quarter of them had undergone caesarean section. So this is a much higher number than the normal numbers that we're seeing. And if you look at the maternal death risk following caesarean section in women from low and middle income countries, again, this is a map with country-specific rates of death. And you can see that Africa, again, does very, very poorly. The red areas are areas where the deaths per 1,000 procedures exceeds 10. And again, Central and Northern Africa do very, very poorly. And if we look specifically at anesthesia, and I know I'm talking also to a surgical audience, but the anesthetic deaths do form an important part of deaths in this setting. This is from a meta-analysis also by Sobey et al. In the Lancet Global Health in 2016. And they showed that anesthetic deaths constitute 1.2 per 1,000 procedures. And that's almost 14%. So 1 in 7 caesarean section deaths in this setting are due to an anesthetic complication. And if you contrast that with the United States of America, where it's 4 to 6 per million, this is a staggeringly high number. When you look at non-physician anesthetists versus physician anesthetists, the non-physicians have worse outcomes than the physician anesthetists. Now, you might say that might be expected, but in the USA, that's not the case. And this potentially relates to training. It also may just relate to the fact that where non-physicians are giving anesthetics, there are fewer resources. In some of the areas that were studied in this meta-analysis, there was less than 1 physician anesthetist per million of the population, which really just illustrates how poorly resourced some of these areas are. And the deaths seem to happen due to airway complications. 3/4 of all of them are either from failure to secure the airway or aspiration around securing that airway. And only 6% are from high spinal, which is a lower number than many people would have expected. Now, if we want to really get to the bottom of this problem, we need to look at prospective outcome studies. And these studies were started in the general surgical population. Rupert Pierce and his group began with USOS and ASOS, which looked at many countries and many hospitals and just looked at what happens to patients when they have surgery. And ASOS has followed on from this. This is Professor Bruce Bickard. He leads the African Perioperative Research Group, which is called APORG. And one of the studies that they've produced was this ASOS study, which was published in the Lancet. And this looked at 183 hospitals with 22 African countries. And what we did was we came along and asked to piggyback onto the study and follow maternal and neonatal outcomes over the 7-day period. So for 7 days, we followed every single patient in these hospitals that had a cesarean section, and then we looked at their outcomes. And we got almost 4,000 patients in that period, and we only looked at cesarean deliveries. And what we found was that there were less than one specialist per 100,000 in the areas that we researched. There were 1 in 200 deaths. And now this is 50 times higher than you'll find in the high-income countries. That would equate to a maternal mortality ratio of 543 per 100,000 and a 17% complication rate, which is 3 times higher than what you'd find in a high-income country. 1 in 22 babies died, and 1 in 11 required CPR. That's a staggering number. Almost 10% of babies required CPR, chest compressions, around a cesarean delivery in this setting. 1 in 8 were either pre-eclamptic or eclamptic, and 1 in 17 had a bleeding risk coming into theatre. 1/4 of the anesthetics were given by non-physician anesthetists. In particular, we found that severe obstetric hemorrhage was a major problem, and hemorrhage accounted for nearly 70% of all the complications, and 25% of all deaths occurred after severe obstetric hemorrhage. So clearly an area to target in this setting. Now, another way to look at this is to look at the complication rates versus the mortality. And if you look at peripartum complications, our rate was 2.5 times higher than what you'd find in the United States of America. Our peripartum hemorrhage was approximately twice as high. And yet, our maternal mortality was 50 times higher. And this is a very striking aspect, that when our patients complicate, they're much more likely to go on and die from those complications than in high-income countries. And we call this a failure to rescue. Put another way, if you looked at the general population in ASOS, the adult surgical patient was twice as likely to die following surgery than in a high-income country, yet the cesarean sections were 50 times higher. The complication rates were only slightly higher in the cesarean section group. So the failure to rescue in an adult surgical population is twice as high than in a high-income country, but 17 times as high in the cesarean section population. So this is clearly an area that we can target to reduce the overall mortality rate. We need to look for those patients that complicate, recognize them early, and treat them early. Now, if you're looking to read about sort of a global perspective around perioperative care, this article by Santhrapala et al. In Anaesthesia in 2020 has a very nice approach to looking at all the different areas that we need to target in improving outcomes in this setting. And they break it into 3 areas. Firstly, we suffer because we're unable to provide timely access to surgical and anesthesia services. And they list how we can minimize each area. The second area is that we fail to then deliver safe surgical and anesthesia care. So even if the patients get to us, we're then not doing the right things in the best manner. And finally, we fail to rescue post-operatively. And it's this area that our study suggests we could target in order to change outcomes, because it seems to be here that we're faring relatively worse than in any other area. And areas you could target in the post-operative period include early risk identification, That risk identification could be preoperatively, intraoperatively, or postoperatively, and it could be linked to a contextualized bundle of care. So that might include checklists, novel monitoring methods. Some of the monitoring that's been suggested is just to get the relatives next to the bed so that they can alert nursing staff earlier, potentially move the bed nearer to the nursing station. It could consider interventions such as lower thresholds for the use of antifibrinolytic drugs like tranexamic acid for prophylaxis. And then we could consider novel methods of training these non-physician anaesthetists, including online support and mobile-based applications. And all of these can be context-sensitive research that's conducted in the setting where the bad results or the outcomes are occurring in the low middle income country settings, context-sensitive research. And hopefully if we can start to target the right areas in the right place, we can start to reduce these still unacceptably high maternal mortality ratios in these areas. Thank you very much.
So David Bishop, thank you very much for a really thought-provoking presentation there. I think we can all agree. Now, next in the session, I'm going to be speaking about safe analgesia. So my name is Neil Muchatuta. I'm an obstetric anaesthetist in Bristol, but I went to school in Zimbabwe. So I'm familiar with working there, and I've done some work with mentorships and other people as well. So I'm just going to start sharing my screen now. So in terms of safe obstetric analgesia, there's a few things that we need to be thinking about. Now, as I've said, I come from... So in terms of safe obstetric analgesia, we're going to be thinking about what we do as obstetric anaesthetists, but I really want to be focusing on how we can work together as a team to improve the well-being and outcome for women in terms of their pain requirements. So as I said, I'm from Bristol in the UK. So this is our maternity hospital. It's not the most salubrious. And we're about 150 kilometres west of London with poor relations in many ways, because this is the typical London couple having their typical London baby. We see this all the time, whereas this is more likely what you're likely to see in a hospital near us. But certainly this makes us think that when it comes to analgesia, we need to be thinking about how we make things different for the different people that we're looking after. Now, for this audience, I don't really need to hammer home the messages from this slide about the pain that women go through during labour. But I think, as someone, who's never given birth myself, and neither have I had a digit removed or cut off, but I don't think I'd like to go through either of those procedures unaided. And of course, the problem with labour pain is that it's not static. And so as you see here, as you move through the hours of labour, the pain increases, whether women are trained or untrained. And also the nature of the pain changes as well. So early on in the first stage of labour, you get a lot more kind of visceral type pain from uterine contractions as well as the dilatation. But later on, it's much more somatic pain, much more down from those sacral nerve roots. So all the way through labour, the women are finding that the pain is ever increasing, but also the nature of it changes as well. So our approach needs to change along with it. And so it's no surprise really that as well as just thinking about the pain scores, when women are asked in more detail about the pain, they'll start to talk in very emotional terms. They'll talk about pain that is sharp, that is cramping, stabbing, throbbing, tiring. So these really emotional words are associated with it. And it's quite interesting that the emotional state of women going into labour makes a difference in terms of their pain, but also how their pain and how their emotions are managed during labour seems to make a difference as well. So if we can help women's anxiety and help keep the labour process as stress-free as it possibly can be, we may well be helping with their pain. So we're going to look at this complex issue over the next kind of 10 to 12 minutes or so, thinking about it in terms of regional techniques that we have available, our pharmacological techniques, and also non-pharmacological. So starting off with regional techniques now, certainly where I work in Bristol, obstetric anaesthesia is pretty much synonymous with having an epidural. So in terms of just a little bit of background anatomy, So this is the epidural space. So this is where we deposit our drugs, usually local anesthetic, often combined with something like opioids, but it then spreads around and has its effect in different areas. So we'll find that as well as affecting the sensory nerves, which is exactly what we're trying to do in terms of pain relief, it'll also affect motor nerves, will have an effect on the sympathetic nervous system, and probably an effect at the level of the spinal cord as well. And this gives rise to the physiological effects that you'd expect with an epidural. So analgesia is what we're hoping for. If we give increasingly large doses, then you start to get surgical anesthesia. So typically we'll give about 10 times the dose of local anesthetic in terms of concentration or volume in order to get that. In terms of motor nerves, you may find that we get some weakness, and weakness in the pushing muscles of the pelvis may give rise to potential issues in terms of obstetric outcomes. And again, with bigger doses, we'll find that the women are unable to move their legs at all, which can be helpful if we are doing a caesarean section under epidural anesthesia. And then in terms of sympathetic effects, then you can get hypotension, though that's pretty unusual in analgesic doses. And side effects, minor side effects are pretty common, so itching. You may find that the analgesia is not perfect, and about 1 in 10 people find it's not perfect, about 1 in 20 need their epidurals replaced. And then hypotension, as I said, is not particularly common. And thankfully, the complications associated with epidural analgesia is pretty rare. So headache is the one that we see most commonly, but many of us will go through our whole careers without seeing any of the others. Now, for this audience, very keen to think about, okay, if a woman has an epidural, how is that going to affect her obstetric outcomes? And thankfully, there's no evidence that there's any increase in caesarean section rate. However, there may be a tendency to seeing more instrumental deliveries, and it may have a slight effect on the length of the second stage of labour. But it's worth pointing out that a lot of the studies that contributed to this understanding were done in years where we used kind of stronger doses of local anaesthetic. And so it may be in modern practice, the most recent analyses are suggesting that these effects are reduced. So if you think about epidurals, it's pretty much what we would determine the gold standard. If we put in an epidural catheter, you get long-lasting analgesia, very high satisfaction rates, and excellent safety record, and no impact on caesarean section rates. However, there are significant staffing and equipment issues, which is why it is not commonly seen in low and middle income countries. It does require expertise in order to do the procedure, but also a huge amount of governance and staffing issues that go around supporting it as well. The women require extra monitoring, it does reduce their mobility, and there's possible impacts on their obstetric outcomes as well. So not the be all and end all by any means. So moving on to what we can do in terms of spinal analgesia for labour. So epidural analgesia would be going into the epidural space. Spinal goes a little bit deeper into the CSF. And in my practice, we commonly combine a spinal and an epidural together. You get rapid onset, very, very reliable analgesia. But of course, because you're inserting an epidural, you have all the downsides of an epidural technique as well. Now, in low and middle income countries, a single shot spinal, it probably looks like it would be quite a positive step in terms of it's a technique that is very, very familiar to people who are involved in providing anaesthetic care, and it's also relatively cheap. However, the downsides are that it's a technique that is, as a single shot, has a limited duration of action, so it may not last throughout the whole of the labour. And there are issues with the side effect profile as well. So if we're using lots of local anaesthetic, hypotension, if we're ameliorating that with some opioids, then fentanyl, with opioids, then itching, nausea, vomiting, and so forth become particular issues. Now, for this audience, local anaesthetic blocks will be very well known. So paracervical blocks, so to help with first stage pains, well tolerated and very effective. However, it is limited in duration again, and there are potential issues with causing fetal bradycardia. And then for second stage pain, pudendal nerve blocks can be effective, although it is very operator dependent. And of course, it's a very vascular area, and so there are risks of local anesthetic toxicity as well. But can be a very useful adjunct, particularly if planning to do an episiotomy or an instrumental delivery. So those are the kind of regional techniques. Now, a bit about pharmacological analgesia. So pethidine is very commonly used as a labour analgesic. However, if you look at the evidence around how effective an analgesic it is, it's not terribly convincing. So if we look at the pain scores on the y-axis, looking at, so you see the pethidine in red there, a slight reduction, but although we would probably say this is fairly modest looking analgesia. But if we start to look at other effects, so if we look at sedation, definitely seeing an effect of sedation and also reduced anxiety and anxiolysis. So many of the detractors of pethidine would suggest that actually it's less an analgesic and more an anxiolytic and a relaxant and provides a bit of sedation. Said that, it's widely used, and that's in spite of the issues with its metabolites. So both pethidine and its active metabolite norpethidine can accumulate in a fetus, particularly a distressed fetus, and may cause problems either with jitteriness or even in terms of respiratory depression and so forth. So one technique that we use pretty widely is use of nitrous oxide as an inhaled analgesic. So it's often presented as Entonox. Although it's not been widely used in low and middle income countries, there is increasing interest. Yet again, in terms of its analgesic efficacy, so if you're looking at pain scores during different contractions, again, very modest analgesia. And yet again, we're seeing some of these slightly supertentorial effects. So in terms of analgesic effectiveness, you see only about half of the women taking nitrous oxide say it was very effective compared to the majority, so over 90% with epidurals. However, they are very satisfied with it. And so there's a degree of control, and it means that they're doing something to aid their own labour pain. And of course, we all know that nitrous oxide has its side effects, and it's been used as a drug of abuse and misuse for ever since it was discovered. And it may well be that some of these other effects come into play in terms of its effectiveness. And I just want to touch a little bit on remifentanil PCA for labour, just because many of you may have read about this in the literature, although it may not be widely available. So it's an ultra short-acting opioid with a rapid onset and offset, and that's because of these non-specific esterase bonds, which get broken down through the body very rapidly. They get broken down in the fetus very rapidly as well. So all of the studies that have looked at fetal outcomes have shown that there's no significant effect. So safe from that point of view, pretty effective in terms of its analgesia. So this is reduction in pain scores. So the higher the bars, the more effective the reduction. But you'll see in all these studies, if you compare them with epidural analgesia, the epidurals are more effective. So they remain the gold standard. But the big question mark over remifentanil is a potent opioid, and respiratory depression is pretty common. And there was a flurry of case reports that happened in kind of 2011, 2012 of women who'd been receiving this form of analgesia and had respiratory and or cardiac arrests. And so that really is a real cause for concern and cause for thought for any people wanting to take up this sort of analgesia. So just to summarize where we are in terms of pharmacological methods, they have very high maternal satisfaction, and actually very good satisfaction with the staff looking after the women as well. With pethidine, certainly midwifery prescribing is common in many countries, and they are, certainly pethidine is of low cost. However, there are the downsides. Most of them are pretty modest in terms of their analgesic efficacy at best. And a lot of them seem to rely on a bit of sedation, anxiolysis, but along with that can go some dysphoria. And then the maternal side effects and fetal side effects are the real concerns with some of them, maternal side effects, particularly for remifentanil. And there are equipment requirements and safety issues again with remifentanil. So pros and cons to both. And then finally, the non-pharmacological. So these are the ways of providing analgesia with the fewest side effects, but also it's fair to say have the least amount of good quality, robust evidence around them. In terms of what does seem to work, so just having your birthing partner with the woman as they're delivering, whether that be their own partner or someone else who is there as their advocate, makes a difference. So it's quite interesting looking at this. So this is from the Cochrane review, looking at the various randomized control studies, but particularly interesting looking at the things on the right-hand side. So increase in normal birth rate, reduction in caesarean section, reduction in instrumental birth, and also improved APGAR scores at 5 minutes. So in terms of kind of benefits and so forth, and against its potential downsides, something really that we should be encouraging. And unfortunately, in this country at least, is something that is being suffering as a result of the current pandemic. And there's sort of moderate to low quality evidence around having people in water, particularly warm water, any form of relaxation technique, including kind of massage, and also the use of acupuncture. However, it's fair to say that most of these studies are pretty small, use different ways of measurements, and more research is needed. And so far, there's really insufficient evidence to recommend hypnosis, TENS machines, or aromatherapy, although they're unlikely to have significant downsides. Sterile water injections and biofeedback haven't really been shown to be successful at all. So just summarizing the non-pharmacological techniques that seem to work, they involve the caregivers. They also involve a bit of relaxation and ameliorating the effects of what's going on during their labor, and allowing the mother to take control over analgesia. And this really fits with what we know from looking at other studies. So this was a qualitative study looking at 14,000 women, and they felt that the people who had the most positive experience were involved in decision making, and that helped temper their expectations and manage those appropriately, but also this concept of having someone with you and the quality of the care that they give makes more of a difference perhaps than the right drug and the right drug technique. So it's all part of a much more holistic process. And if you look at a high-income country setting, so this is from the UK, now what women actually decide to choose in the end is usually not the very advanced techniques. So most women will choose to use things like gas and air, they may use sort of natural methods or going in a birthing pool rather than going for drugs or epidural. Although the eagle eyes of you will notice that these add up to more than 100%. So women will often have try to use many kind of multimodal techniques. So it's also giving them that degree of choice. So just to summarize then, so the pain of labor is an intense, painful and emotional insult. In terms of the things that we have available to us, the regional techniques, particularly epidurals, not too many side effects, but there are occasional complications. All of the drugs and pharmacological techniques we use are not perfect in terms of their analgesia, but certainly are very popular with the women and seem to be well liked and often chosen again. But there are simple things that we as an obstetric team can do in terms of supporting our women in order to improve their experience and thinking about all the things that are really important to them. Thank you very much. So next, we're delighted to be joined by Nicole Fernandes, who is an obstetric anaesthetist and also an intensivist at Groote Hospital in Cape Town in South Africa. And she's going to be talking to us about safe spinal anesthesia in the context of caesarean section. Thank you, Nicole.
Thank you, Neil, and thanks to the organising committee for the invitation to speak about safe spinal anesthesia. As Neil said, I'm an anaesthetist in the Department of Anesthesia and Perioperative Medicine at the University of Cape Town. I have a special interest in obstetric anesthesia, and I'm also currently serving as the fellow with the International Journal of Obstetric Anesthesia. So at the outset of this talk, I think it's important for us to look at why we perform spinal anesthesia at all for cesarean delivery. The main reasons are that we avoid failed tracheal intubation. We know that in the obstetric population, the rate of failed intubation has remained stable over the past 40 years at about 1 in 390. The recent NAP5 audit from the UK has taught us that awareness under general anesthesia for cesarean delivery is a huge problem. Spinal anesthesia promotes early maternal bonding, and we know that when compared with general anesthesia, it also provides improved analgesia. And there aren't only better outcomes for the mother, neonates do better with spinal anesthesia too. And there's supposedly less anesthesia-associated maternal mortality, or is there? So if we look at anesthesia-related mortality in high-income countries, it's incredibly low. And the Embrace UK confidential inquiry from the 2015 to 2017 triennium reports only one maternal death that was directly due to anesthesia. And this is in stark contrast to some of the data which Dave has already showed us earlier. This systematic review from the Lancet Global Health showed that anesthesia accounted for 2.8% of all maternal deaths, and exposure to general anesthesia actually increased the odds of maternal death 3.3 times as much as spinal anesthesia did. In sub-Saharan Africa, we seem to be doing worse than anywhere else, with maternal mortality rates attributable to anesthesia of 1.5 per 1,000 women. And as Dave already shared, South Africa is one of the only African countries that does collect data and reports on maternal deaths through a confidential process and has been doing so since 1997. Alarmingly for us, in our 2011 to 2013 triennium, deaths due to spinal anesthesia actually accounted for more than 50% of all anesthesia-related deaths. So this is a really unusual situation. And it's probably that people are now taking a cavalier approach towards spinal anesthesia, and it's being performed by inexperienced clinicians in rural areas where they don't have access to the skills and to the equipment that they need. So what do we actually do during a spinal anesthetic? Well, as you can see on the left-hand side, we introduce a spinal needle into the intrathecal space. We then inject a combination of usually a local anesthetic with an additive, most often an opiate, into the cerebrospinal fluid. If we look at the image on the right-hand side, we can see that the sympathetic trunk has a thoracolumbar outflow from the spinal cord. So the local anesthetic mixture that we inject not only anesthetizes our sensory and motor nerves, but also our sympathetic trunk, resulting in a rapid onset sympathectomy with very little time for cardiovascular compensation. And this is in stark contrast to what Neil has just explained happens when a parturient receives an epidural. The most common effect of this is that we have a patient with usually a rapid onset of around a T2 to T4 block with spinal hypertension. So what contributes to spinal hypertension? Well, first we need to look at venous mechanisms. So we know that venous return depends on the mean systemic filling pressure and what your stressed versus your unstressed volume is in your venous capacitance vessels. Now we can increase our stressed volume by giving more fluids or by inducing vasoconstriction. In a normal fluid-replete, healthy parturient, this venodilatation, the complete venodilatation that is a result of sympathectomy, is usually well tolerated, even in the supine position with the contribution of aortocaval compression. The problem comes in the patients who have experienced intravascular losses, such as a patient with maternal hemorrhage. These patients are highly dependent on the maximally vasoconstricted state of their splanchnic vasculature. And when we induce venodilatation in these patients, the gradient from the splanchnic vasculature to their right atrium decreases, and this can lead to catastrophic cardiovascular collapse. So how much does this venous circulation actually contribute to spinal hypertension, and can we do anything about it? Well, Rout and colleagues showed about 20 years ago that the rapid infusion of a crystalloid preload was relatively unsuccessful in preventing the hypotension that we see with spinal anesthesia. From our own institution, Daya and colleagues showed that a crystalloid or a colloid coload is better, but actually hypotension does still persist. So therefore, therapies that are based on the concept of caval compression and the consequent decreased venous return don't really prevent hypotension after spinal anesthesia to a meaningful degree. One must look at the issue of aortocaval compression and left lateral tilt. This paper from Lee and colleagues that was published in 2017 showed that there was no difference in neonatal pH or base deficit in patients who were supine as compared with those who were tilted. However, in a supine group of patients, more vasopressor was required. And if the degree of tilt was less than 15 degrees, 7% of women actually had a more than 20% decrease in their cardiac output, which is obviously highly significant. There was an accompanying editorial that went with this paper that therefore did not recommend the abandonment of left lateral tilt, as it can be absolutely catastrophic in some women at caesarean delivery. So if the venous mechanisms don't fully explain why spinal hypotension develops, we need to look at other mechanisms. And then we move our attention to the arterial system. Arteriolar dilatation after sympathectomy does occur and leads to a decrease in systemic vascular resistance of up to 35%. And this has caused us to shift our attention to the role of vasopressor management in the management of spinal hypertension. So then, considering that there's a dual physiological process involved in the development of spinal hypertension, we need a dual management strategy, and therefore we need to try and target both the venous and the arterial systems. This work from Warwick Nankee that goes back to 2005 just did just that, and they show that it's effective to use a combination of vasopressor therapy together with crystalloid cohydration in order to manage spinal hypotension. And this still holds true 13 years later if we look at these recently published consensus guidelines on the management of spinal hypertension. So these authors still recommend the use of left lateral tilt. They recommend either a crystalloid preload or a colloid coload as their fluid management strategy. And they have quite a tight blood pressure target. So they aim to maintain systolic blood pressure greater than or equal to 90% of the patient's baseline and not allowing it to drop to less than 80% of the accurately measured baseline. And this really does improve maternal comfort, especially in terms of decreasing nausea and vomiting. One of the problems with these guidelines is what the way that they recommend the use of vasopressors. These authors recommend that we use a variable rate phenylephrine infusion via an infusion pump at 0.25 to 0.5 micrograms per kg per minute. That being said, there is a whole section of these guidelines which are dedicated to their implementation in low-income countries and resource-poor settings, which is incredibly welcome. So context, of course, is always king. And what do we do in our resource-constrained environments? Well, these authors, Buthelezi and colleagues from KwaZulu-Natal, showed us that if infusion pumps aren't available in your institution, the addition of 500 micrograms of phenylephrine to the first liter of Ringer's lactate, which is administered to parturients after their spinal injectate, can be used for the management of spinal hypertension. And in fact, when compared with just bolus phenylephrine alone, they showed a 29% reduction in hypotension, and only very occasional hypertensive episodes were noted, with no difference in the number of bradycardic episodes between the groups. So when we're looking at safety, we have to think about what sorts of drugs we're giving to these patients, and the choice of vasopressor that we're using becomes very important. Initially, obstetric anesthetists were reluctant to use phenylephrine as there was a sheep model that showed that it might decrease uteroplacental flow. We now know that that's not true. And in fact, ephedrine causes a lower umbilical arterial pH in the neonate, a worse base deficit, and more hyperlactatemia. And this is because of a direct effect of ephedrine on the neonatal metabolic rate. What about noradrenaline? So this has become quite controversial in the last sort of 3 to 5 years. Proponents of the use of noradrenaline as a vasopressor favorite because they say it produces less bradycardia as a result of its modest beta effects of the drug at low doses. One must bear in mind, though, that these studies are coming out of very high income countries, sophisticated labor wards, where they have very advanced pumps with closed loop mechanisms that can change the dose of the drug being administered appropriately. When using a bolus of norepinephrine, the authors of these two papers suggest that the ED90 is around 6 micrograms. But at what cost are we going to be using such a potent vasoactive drug? Bradycardia with phenylephrine is actually rarely a clinically significant occurrence that results in patient harm, but the dangers of using a vasoactive drug that is actually 12 times more potent than phenylephrine outside of an ICU setting in a resource-constrained environment has to be taken into account. We have a perfectly good agent that treats spinal hypotension well in phenylephrine, and is the search for perfection, in this instance, not the enemy of good. In low-income countries, we cannot recommend the use of norepinephrine for the management of spinal hypertension. As I alluded to earlier, in South Africa, we're facing a crisis where our deaths due to spinal anesthesia are incredibly high, and that led to the development of these guidelines on the management of high spinals. These authors teach pattern recognition in response to spinal hypertension and spinal anesthesia, and they provide a great treatment guideline that was developed in and for low-middle income countries. So if we look at the patterns that they teach, the first that they speak of is the usual response to spinal anesthesia, which is hypotension and tachycardia. And as we've said before, this is easily treated with fluids and vasopressors. Another pattern which we might see is the patient who presents with hypotension and an unexpected reflex bradycardia. So at all times, one must have an anticholinergic agent ready and available, and these are often atropine or glycopyrrolate. And the most feared pattern of all, and what can be considered a complication, is a high sensory motor block, which is rare but can be fatal. Whilst I appreciate that you as obstetricians might be otherwise occupied during the situation of a high spinal, it's of utmost importance that everyone who is managing these patients understands and is familiar with the key management principles of a high spinal. We need to discuss the situation and perform simulation training on it often in the labor ward and in theatre. The anaesthetist must always be prepared and recognize the problem early and call for help. Respiratory support in the form of tracheal intubation should occur immediately after vasopressor administration, and it might be necessary to run an adrenaline infusion if cardiac output is not restored. And that patient then needs to be monitored very closely until that block recedes. In an area where ICU is not available, this might mean keeping the patient in your theatre intubated on adrenaline until their block has receded adequately. So in an attempt to mitigate risk further, people have looked at the dose of the intrathecal agents that we give. Standard practice in our institution is to use 2 mils or 10 milligrams of heavy bupivacaine in our spinal anesthesia. And this paper looked at low dose bupivacaine for spinals, and they reported that if you use a dose of less than 8 milligrams, you have a 3.8 times increase in the need for analgesic supplementation via the intravenous route. And rather than decreasing risk, in fact, this probably increases risk. This means that you're putting yourself in a situation where you may need to convert to general anesthesia, where patients are at higher risk of having apnea and respiratory arrest, especially in the usually less monitored recovery area. And this might lead to hypoxia and aspiration. There are certain groups that we need to consider on their own when we think about safety of spinal anesthesia. And the first of those is the obese parturient. So there's a concern that the spinal dose should be reduced in these women to reduce the eventuality of a high block. But Carvalho and his colleagues have shown that the effective median dose is actually 9.8 milligrams. And as I said, what we use as a standard is 10 milligrams. From our own institution, Chris Ngaka studied block height and vasopressor requirements in obese parturients. And he found that although their temperature block was 2 dermatomes higher than non-obese patients at 25 minutes, there was actually no difference in the phenylephrine requirements between the two groups. So they didn't have more hypotensive episodes than their non-obese counterparts. The next group that we want to talk about is the preeclamptic patients. So there were early fears concerning the fact that intravascular volume was depleted in preeclamptics and that they were at theoretical risk of hypotension or severe hypotension with spinal anesthesia. But our research in the past 25 years has actually shown us that that's not true. And spinal anesthesia is incredibly safe in preeclamptic patients as long as there are no contraindications present. So the special situations which we need to always keep in the back of our mind is the patient with HELLP syndrome and low platelets, a patient with left ventricular systolic dysfunction, which most often presents as pulmonary edema, and the patient who's experienced some sort of hemorrhage, which in the setting of preeclampsia is most often an abruption. And these hemodynamic changes in preeclamptic women who are undergoing spinal anesthesia are not something that we've only started studying now. As far back as 1950, people have been interested in this. This itself is an amazing study where women who, healthy pregnant women, preeclamptic pregnant women, and non-pregnant volunteers were actually given either a ganglion blocker or a spinal anesthesia simply to see what happened to their hemodynamics. I mean, one would never get this past an ethics committee in today's day and age. But what the authors found was that in the preeclamptic group, there was actually a very modest decrease in their systemic vascular resistance and their afterload, and that spinal anesthesia was very well tolerated by the preeclamptic women. This was confirmed many years later by work from our own institution. And as I said, there's a very modest decrease in afterload, which in preeclamptic women who are likely to have diastolic dysfunction is actually a very favorable hemodynamic state to be in. Preeclampsia then, of course, takes us on to considering the eclamptic patient, and each of these patients requires an individualized approach. So consider this woman, for instance. She's obese, she's bitten her tongue. She has a GCS of 15 after her seizures have terminated, but she presents with fetal distress, a blood pressure of 160/110, and no platelet counts available. This is a disaster in decision-making for the anesthetist. If you embark on a general anesthetic, you're at risk of losing this patient's airway and exposing her to a hypoxic event. If you perform a spinal anesthetic on this patient, you're at risk of exposing her to an epidural hematoma formation or neurological fallout. Moodley and colleagues showed us that in a series of eclamptic women, regional anesthesia was safe, provided that the patient's seizures have terminated, her GCS has returned to 15 out of 15, and there are no residual signs of raised intracranial pressure. In order to maintain the safety of spinal anesthesia, ongoing teaching and training is essential. And as we'll hear shortly, programs such as the ESMO-E guidelines and safe anesthesia are working to do this. In our own institution, we often ask about intern requirements. What really is the acceptable minimum? How many spinal anesthetics should one practitioner perform before we say that they are capable of doing so on their own without supervision? In sophisticated first world countries, simulation training happens often, and in American institutions, they've shown that in obstetric anesthesia, particularly with a good simulation program, trainees retain their skills for 8 months post-training and are trained up to the level of an attending obstetric anesthetist. In these same high-income countries, parturients are seen and respected as a high-risk, vulnerable population. Obstetric anesthesia is only ever a senior trainee rotation, and there's little to no care provided without direct supervision. So whilst we can appreciate that this situation is unlikely to be attainable in the near future in our low and middle income setting, hopefully we move away from the notion that it's just a spinal, and the safety of spinal anesthesia improves for women in Africa. Thank you.
Nicole, thank you very much for that. And I think it was really interesting to just challenge some of our assumptions about how safe spinal anesthesia at caesarean section can be if we just look at evidence from high-income countries and don't think about our local settings. So next, I'm delighted to introduce Ada Ejiofor. So she's a consultant anaesthetist at Guy's and St Thomas's Hospital in London. And she also has a background in performing arts, and so is always an excellent presenter. And she's going to be talking to us today about safe general anaesthesia for caesarean section. Ada.
Hello, everyone. Thank you, Neil, for that very kind introduction. I'll be sharing kind of like a whistle-top tour of general anesthesia for caesarean section and what kind of safety standards would be both realistic and pragmatic in low and middle income countries. Now, the theme of this entire session is what the surgeon needs to know. So in other words, what we would like our surgical colleagues to know. But I think I'll take the liberty to extend that a bit further. What the surgeon needs to know, acknowledge, in other words, accept the known facts, and then act upon the known facts. And I think I need to stress that these are 3 levels of engagement which need to be present. Otherwise, we enter a scenario, which I think everybody's probably seen that video, I don't know, over and over again, where there's a deadlock between the anesthetist and a surgical colleague because the patient has a pH of 6.8, has a potassium of 5.9, but the surgeon is going on, there is a fracture, I need to fix it. Now, there's a slight difference between fixing a fracture and performing a caesarean section, because obviously a caesarean section belongs on the list of essential surgery. But I think a fact that needs to be acknowledged is that even though the need for a caesarean section arises everywhere, a safe caesarean section cannot be performed everywhere. Now, that's a bitter pill to swallow, especially in the light of the findings of the ASOS study, which I think Dave Bishop would have shared with us, which has shown that similar to the pattern in other parts of the world, the caesarean delivery is the commonest operation performed in low and middle income countries, and definitely in Africa, as ASOS has ASOS has demonstrated, sorry. But the reality on ground is that we cannot perform safe caesarean section everywhere. And I think it's being in touch with reality when we draw those lines. Safety is a multimodal issue. Safety is much more than just the presence within a hospital or an institution of surgical technical expertise. So people who are skilled in performing a caesarean section, that's not the whole picture of safety. And the whole picture needs to be taken into account. And since we're having these conversations with our surgical colleagues who are in positions of clinical leaders, presidents of regional colleges and professional associations, we need them to acknowledge and act upon the fact that there might be limitations in the environment, and the limitation is not in any way a negative commentary on their technical skills, but factoring in those limitations of environment might mean that as a medical community, we accept that caesarean sections cannot be performed in every institution where there are people who have the skills to perform them. And I thought I should get that out of the way because there is international guidance and there are recommendations for the safe conduct of general anesthesia for caesarean delivery. But because these recommendations have been generated in countries and environments where the reality on ground is quite different from what we have in low and middle income countries. There is no statement about appropriateness of environment or skill set. That is now in the high income countries, a fact that's taken for granted. That so it doesn't really feature in the discussion anymore. But that's just to say, it gives an indication of the level where we are at. So in the course of this discuss, I will have as a backdrop the practice guidelines for obstetric anesthesia, the updated report by the ASA task force on obstetric anesthesia. And this document was written in conjunction with SOAP. There are, of course, other guidance documents generated by organizations such as NICE, the American College of Obstetricians and Gynecologists, the Royal College of Obstetricians and Gynecologists, and the Difficult Airway Society has guidelines on management of the difficult airway specific to the obstetric patient. But the ASA guidelines tend to be the one that I'll zone into, because this was written by a community of anesthetists or anesthesiologists. And using that as a backdrop, as we go through, I'd like for us to attempt to achieve a pragmatic, realistic take on international guidance. What sections of the guidance can we realistically translate to resource-constrained environments? Because I think a fact that we can all agree on is that a resource-constrained environment can be made safe. It can be made as safe as is possible in the circumstances. And resource-constrained should not be taken to automatically mean unsafe. And that's the challenge. The other document that I would be using as a springboard is a review by Sobey and colleagues. This is a 2016 paper where he reviewed anesthesia-related maternal mortality in low and middle income countries. And in that review, the incidence attributed to anesthesia was 2.8%. Now that, on the surface of it, might look as if it's a small figure. But then when one probes or interrogates this figure deeper and realizes that for patients who had a general anesthetic for cesarean delivery, the incidence of anesthesia-related maternal mortality in this review was 900 times the quoted figure for the United States. And for patients who'd had an uraxial block, it was 300 times the rate quoted from the United States. So obviously, this just puts a figure to what we already know, and that's that we are lagging behind in low and middle income countries in reducing the mortality and morbidity attributable to anesthesia. And three main themes arose from this systematic review, and you would not be surprised that they are similar to the themes that have arisen from similar reviews all around the world. Airway management, complications arising from airway management accounted for 45% of mortality, aspiration 31%, and issues to do with staff competence and equipment accounted for 27%. And so, if I may borrow a leaf from Rudyard Kipling's poem about 6 honest serving men, the what, why, how, where, who, and when, I'd just like us to run through those honest serving men as it applies to the conduct of a safe general anesthetic for cesarean delivery in low middle income countries. So, who should be present for this surgical procedure to be conducted in a safe manner? There are constraints peculiar to low middle and income countries, but I think in the 21st century, we can all accept, and I don't think that there'll be much debate about this, that the surgeon cannot at the same time be responsible for the anesthetic. So the old pattern where the surgeon tried to be all things in one, you know, to be responsible for the anesthetic, to do the cesarean delivery, and sometimes even be his own scrub nurse for a variety of reasons, which ranged from unavailability of personnel to sometimes just a cost-cutting exercise. I think that no longer belongs in the 21st century, wherever. And so the surgeon cannot at the same time be responsible for the anesthetic. There should be present an anesthetic assistant, there should be a scrub nurse, and there should be staff to resuscitate the baby. It should not fall to the lot of the professional who is responsible for providing the anesthetic to, at the same time, be responsible for resuscitating the baby, because in situations where the mother starts to need more and more attention, that can be a distracting item, and sometimes with very undesirable consequences. And of course, in addition to all these people, you need an anaesthetist with sufficient skills and training. Now, what are the items in this sufficient skills and training? An anaesthetist, and you notice I use the word anaesthetist without referring to whether it's a physician, a nurse, or just simply somebody who's been technically trained. I think the important thing is to zone into the skill set. We all are aware that there's a heterogeneity of practice in low middle income countries, and particularly in sub-Saharan Africa. So one cannot be too didactic about the cadre of healthcare professional, but the skill set we need to be fairly insistent on. The provider should possess sufficient experience with face mask and Goodell's airway. Mothers do not die from failure of intubation, mothers die from failure of oxygenation. And so the healthcare provider must be sufficiently experienced and confident, if need be, to conduct a caesarean delivery under a face mask and a Goodell's airway. The provider should also have sufficient familiarity with intubation in the obstetric patient. But as we do know, there can be scenarios where it becomes impossible to intubate the mother and more dangerous to persist with unsuccessful attempts at intubation. And so there must be a plan A, a plan B, and possibly a plan C. It is desirable that our healthcare providers providing anesthesia for obstetrics should also have sufficient experience with the use of a stillet, a bougie, and at least one supraglottic airway. Kingma et al. In 2017 did, and this is the reason I quote from this study, is it was performed in sub-Saharan Africa. There are other studies showing similar results, but this is closer to home. And in a simulated difficult airway study amongst a group of anesthetists, he showed that a use of a stillet or a bougie can increase the first pass success intubation rate to more than 90%. And so there should be, within the framework of teaching, a deliberate attempt to ensure that those who are anesthetizing in obstetrics are familiar with and recognize scenarios where they should proactively use an intubating aid to increase the chance of first pass success, because the first attempt usually is the best attempt. The healthcare provider should also be familiar with the concept of escalation within and without. And as simple as this sounds, one cannot always take it for granted in some settings where cesarean deliveries are being done, that the provider who is in the operating theatre actually has some kind of plan of who to call if he or she runs into trouble. But this concept of escalation should exist. And yes, the question may arise, what about if it's a scenario where the person in theatre is the help? Then call another person of equal training with yourself. As they say, hunting, there's safety in numbers. And that's something that we tend to believe in anesthesia. And so in these environments, there should be that concept that you can call somebody else, just an extra pair of hands if you run into a difficult situation. Again, simple things that are taken for granted in environments that have greater technical expertise, but cannot be taken for granted in low middle income countries. Now, aspiration prophylaxis was another big theme in SOBI's review, accounting for maternal mortality. The time to prevent aspiration prophylaxis, obviously, is before the operation actually starts. Reviews have consistently, Cochrane reviews have shown that clear antacids are potentially the most effective pharmacological agent in raising the pH of gastric acid. I can say, having done a fellowship in anesthesia in 2 different continents, that throughout my training in sub-Saharan Africa, I never saw 0.3 molar sodium citrate in theatre, not once. So it is a recommendation, but the reality on ground is it does not make its way onto the formulary of many hospitals. Now, this is an organizational systemic thing that, again, we need to start developing pathways to address. But for the practitioner who's on the ground, the reality is the theory, they know the theory, but it's just not available. The next is H2 antagonists. Now, that ranitidine, for one, seems to make its appearance in most environments, no matter how remote. And so parturients coming for cesarean deliveries should be prescribed H2 antagonists in tablet form, if it's an elective cesarean delivery, and if it's an emergency, it can always be given intravenously at a dose of 50 milligram intravenously and 150 milligram orally. This seems to be relatively more available compared to clear antacids. Prokinetics, the evidence is not strong in favor of prokinetics because obstetric patients have normal gastric emptying times. However, for emergency cesarean delivery, I think there's some merit in advocating that metoclopramide, which again appears to be a drug that's present in even the most remote of environments where cesarean deliveries are performed, that metoclopramide, for both its prokinetic and antiemetic action, should become part of the teaching of what needs to be given for an emergency cesarean delivery, not the electives, but for the emergencies. Now, how do we conduct safe general anesthesia for obstetric, for cesarean deliveries? And it starts with the planning. Plan, prepare, position, pre-oxygenate. All these words start with P, but each of them is really important. Planning involves an assessment of the patient, no matter how urgent the emergency is, it is always possible to ask the patient to open their mouth and do an airway assessment. That already can flag up some warning about whether this airway would be an anticipated difficult airway or not. The obstetric airway, of course, we are advised to always prepare for the obstetric airway as if it is a difficult airway for a variety of anatomical reasons. And so the preparation should also involve getting the necessary kit, which, as I mentioned, should include a stillet and a bougie, and positioning. And on the issue of positioning, which is something which surprisingly can make a massive difference, but in areas in low middle income countries where I have worked, over and over again, the absence of a pillow is almost like taken as the norm. And granted that on many days, it would not be an issue because many patients are not a difficult airway, but more and more we're seeing patients with morbid obesity and all kinds of other factors, acquired factors that make them a difficult airway. And it is in that day that the resident working out of hours who has not been trained to properly position the patients as a routine for every patient gets into trouble. And so positioning is something that I think we can eminently do, no matter how remote or how resource constrained the environment is. And it just takes formulating a bit of creativity to formulate a ramp which will allow us to align the sternum to the tragus. Anesthesia is not a disease, and strictly speaking, anesthesia by itself is not a treatment for a disease. So any anesthetic-related death is purely iatrogenic and therefore preventable. And so the onus is on us to practice the simple things which we can eminently do, but to practice them faithfully. pre-oxygenation, adequate pre-oxygenation, and the old teaching, which still remains true, is that pre-oxygenating a patient with a tight-fitting mask, 100% oxygen for 3 to 5 minutes, will result in an end-tidal oxygen concentration of more than 90%. And I think that should be emphasized to whatever the level of healthcare provider who is anesthetizing for caesarean section. These are pillars of safety, and these are those pillars which are simple enough that they can be reproduced in any environment. And I think these are the ones that we really need to stress. So a pillow should be regarded in a caesarean delivery as part of the toolkit, not something, it's not just an item of linen, which if it's there, fine. If it's not there, it's inconvenient. It's actually part of the anesthetic kit. So the guidelines for the performance of a general anesthetic in high-income countries has moved on, and the recommendations have now even moved on from the traditional rapid sequence induction involving thiopentone and SUCs to rocuronium, to propofol and rocuronium. Again, this is one of those instances where one would have to take a practical and pragmatic approach and say that that guidance, it may be possible to implement that guidance in private institutions and perhaps some well-funded tertiary institutions, but that does not represent the landscape. And so I think for many low middle income countries, the reality is that the traditional rapid sequence induction comprised of thiopentone, SUCs, and an informed assistant performing pipette pressure will still be the norm. And that's fine, as long as it's done according to the prescription and with everything that needs to be in place, which includes functioning suction. And suction which should remain in theater throughout the performance of the operation. Now, moving on from the classical GA, my presentation would not be complete on this topic if I then did not return to something that is a bit of a favorite topic with me, and that's the alternative GA, which, depending on which school of thought you belong to or where you work, tends to generate a lot of excited debate and controversy, and that's the ketamine total intravenous anesthetic. The reality, which has been acknowledged by reviews and as well as the WHO, is that ketamine in low middle income countries is still a drug that has a place in the performance of a general anesthetic, literally as a sole agent. It has advantages in that the patient maintains their own airway. It does not require people to have intubation skills, and so it avoids the problems of difficult airway management. If it is managed by somebody who knows the preemptive measures to take, it also avoids the risk of aspiration. And so it is an anesthetic. It is an alternative. And I think the time has probably come when, rather than criminalize it, we now need to actually start actively teaching people how to do it and how to make it safer. The contraindications to using ketamine as a total intravenous anesthetic would include hypertensive disease, so preeclampsia, eclampsia, psychiatric disease, and epilepsy. Steps that need to be taken prior to the start would include anti-emesis. As we know, ketamine is emetogenic, and in cumulative doses even more so. And so that would involve the administration of IV metoclopramide or ondansetron if available. Again, as I have said, metoclopramide appears to be an antiemetic that no matter how remote the region in sub-Saharan Africa, I seem to have encountered it. So it would always be the one I would first mention. ketamine also generates a lot of secretions, and in the presence of a lot of secretions, then an airway that's not intubated can then be at danger. And the way this is mitigated is by giving an anti-sialagogue. Usually it's IM atropine, which is given as part of the pre-med before actually starting the procedure. But as I said, I think as an anesthetic community, we need to get to a stage where we start to actively teach the ketamine total intravenous anesthesia with a view to making it safer, and with a view to also creating some kind of awareness in those who come from high income countries to work for, albeit for a period of time, in low income and middle income countries, so that there's an awareness of how this anesthetic can be conducted. And when they arrive, rather than trying to change everything and introduce things for which there is not adequate, there are no adequate skills or even equipment, rather they can help to make the ketamine TIVA safer. Monitoring, I think we've got to a stage now where we've agreed in low middle income countries, the minimum is a pulse oximeter. And thankfully, Lifebox Foundation has been doing a lot of work in this regard to make this as accessible as possible. And the feedback and the reviews suggest that this is making a difference. So a pulse oximeter, a blood pressure cuff, which is present in every facility, including even primary healthcare, between these two, and of course, looking at the color of the patient and the surgeon monitoring the color of the blood, these would be the bare minimum that should be present for safe conduct of general anesthetic for cesarean delivery. Now, moving on to the post-operative care, that would include all the normal things. So nothing new. Of course, we are aware that many low-middle institutions in low-middle income countries do not have a dedicated recovery area. That should not completely obliterate the concept of recovering the patient. Patients can be recovered in theatre, and we do that. Patients can be recovered in the room next to theatre, and we do that. And what that means is they are still within the eye of the theatre team. They should still have a pulse oximeter on, and it also enables rapid detection if the patient starts to develop complications in the immediate post-operative period. And so post-operative care can be, a modified version of post-operative care should be a basic minimum for cesarean deliveries to go on in any institution. And as I said, it's not necessarily the name of where it is done, it is what is done. And so that brings me to the end of this presentation on what can be a realistic and pragmatic take on the guidelines for the conduct of safe anesthesia for cesarean delivery in low middle income countries. Thank you for your kind attention.
Ada, thank you very much for that really interesting and entertaining talk. So next on, we're going to be joined by two speakers. So first of all, Dr. Andrew Kintu, who's the lead obstetric anaesthetist at the new Malago Specialist Women's and Neonatal Hospital in Uganda. He's also a lecturer in Makerere University and the outgoing president of the Association of Anesthesiologists of Uganda. And in a great bit of team working, he's going to be joined from across the world by Dr. Maytinee Lilaonitkul, who is an assistant professor at the University of California, San Francisco, and the Faculty Division of Global Health Equity. She's on the publication committee of the World Federation of Society of Anesthesiologists and is the editor-in-chief of an online educational resource, Anaesthesia Tutorial of the Week, which I can highly recommend. She's also the obstetric lead for the International Safer Anesthesia from Education program, known as SAFE. We're going to be hearing from them about team working and how SAFE can be used as an influence on that.
Thank you, everyone. So talking about self-obstetric course. So the SEF course was developed by Association of Anaesthetists of UK and the WFSA in 2011. And this was tailored to the low resource context. And this is packaged in an off-shelf way in which it's a modular state in which the different topics can potentially be delivered separately. It also utilizes adult learning principles, which are highly interactive with a variety of teaching modalities. And more of the emphasis is that the SEF course, wherever it was carried out, it embedded trainer of trainees to help build local capacity so that the training can go on even after the initiators have left. The SEF course has a variety of topics of emphasis. They do a lot of spinal anesthesia, put emphasis on neonatal resuscitation, topics like obstetric hemorrhage. We have maternal physiology, preeclampsia, but most of the emphasis was put on things like communication and teamwork, including both communicating with the surgeons, the anesthetists, and all the other people as part of the team in the management of these obstetric cases. Since its inception and pilot course in Uganda in 2011, the WFSA has partnered with different societies of anesthesiologists around the world to deliver the course in over 43 countries, with about 93 courses being run so far. And this has seen about 3,582 anesthetists providers being trained through this course, and has gone far around the world, with a lot of faculty being trained in the different countries, with about 634 people being trained. Currently, it has moved as far as Fiji. So when it comes to Uganda, just a few statistics about Uganda. The national caesarean section rate is about 7.1 as of 2016. And with some facilities, mainly referral centers, going as high as 30% caesarean section rate. And most of the burden of surgical services in Uganda are mainly caesarean sections. When you look at the different anesthesia providers in Uganda, Uganda has about 400 non-physician anesthetists who do the bulk of the work, with only just about 68 anesthesiologists, and most of these are mainly in the urban centers and training centers. And all these together cover a population of 45.74 million Ugandans. So in 2011, the SEF course was initiated in Uganda as a pilot course. And by 2014, the entire country had been trained in terms of the different regions of Uganda in terms of SEF obstetric anesthesia course, with about 366 anesthesia providers, which was close to the target which they had set of about 370 people. And this also saw about 40 trainers being trained as local faculty within the country to enable the course to carry on even after the initiation of pilot project. So the impact in Uganda, the most important thing that was realized from the SEF course was mainly networking between the clinical officers, who are the non-physician anesthetists, and the anesthesiologists. And this started way from the training part where the course was being delivered. There used to be sharing of experiences, that is from the clinical officers and anesthesiologists. And then this also carried on via phone consultation, mainly between the faculty who had been in the training of the course and the people who participated. Even when they went back to their local centers, they kept on calling and discussing the different cases. And many cases were also managed on phones. And then there was also a feedback that usually came back from their centers where these anesthetists or the clinical officers had come from, with people telling us that there was better communication between the surgeons and anesthetists and the nurses, and also case discussions with their own surgeons. And many of these participants, the clinical officers, actually became advocates of change with continued consultation with the anesthetists the anesthesiologists who are part of the safe course faculty.
Thank you, Andrew. And so just learning from our positive experience of our pilot courses in Uganda, our organization and team are now focusing heavily on the monitoring and evaluation of impact of safe course in low resource setting, and especially in sub-Saharan Africa. Kirkpatrick 4-level model is a well-known evaluation model used to look at results of training programs and education initiatives. It's based on 4 levels of increasing complexity of analysis, starting from reaction, which is learners' satisfaction with the training program. Then level 2 is learning. So we assess knowledge and training acquisition, which is what we're most all as educator well-versed with by applying tests. But what I think we are really interested in is behavioral change and how these learners are able to translate what they learn into practice so that they will enable them to then achieve our final results. And in this context is patient safety and improved maternal outcome. As we know, if we don't measure and see the effectiveness in application of behavioral change from what they've learned, it is a bit too far-reaching and skipping a step by measuring the results and outcome in level 4. As such, we're now focusing heavily in our current studies on behavioral change of our participants. And what we're using and basing our study on is a known implementation science framework called the COMBI framework, where we look at the essential factors required for a participant or a clinician or learner to change their behavior. And this looks at 3 essential components, which includes capability, motivation, and opportunity. And what this means, just to elaborate a little bit more, capability touches on both psychological capability, and that's knowledge, and physical capability, which is a skill, such as to intubate, to perform safe spinal. Opportunity includes both physical opportunity, which is resources, blood, monitoring equipment, laryngoscope, spinal needles, and social opportunity. And when we talk about social opportunity, what we mean is support from peers around us, colleagues, and also from leadership, so that it can help us advocate for the change that we're trying to make. All these leads to positive and negative feedback loop in a dynamic system, leading to motivation in order to motivate the individual to implement behavioral change at the workplace. So just demonstrating level 2, which is knowledge and skills acquisition from SAFE. This is a study we did following up on over 100 participants of SAFE across Kenya in 63 institutions. And we assessed them on 4 different skills, including maternal, cardiopulmonary resuscitation, newborn resuscitation, eclampsia management, and rapid sequence induction using low fidelity simulation. And as shown, their scores increase compared to pre-course during the immediately post-course, and this is sustained at follow-up, which is usually between 6 to 12 months. These result is also replicated in other studies for our monitoring and evaluation in countries such as Zambia and other parts in East Africa. Demonstrating then the behavioral change Kirkpatrick level 3. This has shown to change reported changes through interviews that they've changed in their clinical skills in terms of obstetric hemorrhage management. And as you can see, using a more structural approach, such as airway, breathing, circulation when dealing with the critically ill mothers, management of eclampsia, and also improving their skills in spinal anesthesia. Other emerging themes that we also notice is that participant mentioned that it has greatly improved their communication, especially with the surgeon, and also teamwork, where they're able to have strengthened interaction within the operating room. This study that I'm showing you here is from SAFE courses that was run in Madagascar and the Republic of Congo. Taking all our results into account, we then try to take a deeper dive and see what are the facilitators and what are the barriers that's enabling change and preventing change of these behavior, our learners' behavior in their workplace. We were then able to create a Pareto chart, which is what you're looking at right now, which prioritize what is the leading barrier in order. So the most commonly mentioned was physical opportunity. And as Ejiofor mentioned, these are lack of equipment and human resource are the biggest barrier in low resource setting in order for them to implement change that we teach on the SAFE course. However, many also mentioned that actually the lack of social opportunity, and that is peer support and teamwork, makes them feel unempowered and the ability to implement the changes they've learned. Some of the quotes includes, the World Health Organization checklist cannot be achieved in this environment. By myself, I cannot implement this thing. It is supposed to be carried out by the whole team. Some also mentioned that the surgeon complains about them doing a left lateral tilt on the mothers on the operating table. One participant also reported that he was struggling to make any changes. He was the only person who was trained on SAFE. And as such, it helps us highlight that a critical number is required of people to help bring about change, and that peer support is essential in providing motivation for these learners to implement the change. So all the studies I've mentioned so far are reported changes. That means it's through interviews. And so we're interested in actually now looking at whether these reported changes are also playing itself out in the actual workplace. And so our current study, we're carrying a prospective observational study in southwest of Tanzania in Mbeya, having observers within the operating room and seeing if their behavior, both technically and non-technical skills such as communication, has improved. The study is still ongoing, but our interim finding shows that there is an increased uptake of the WHO checklist completion, as you can see, starting from almost less than 15% and up to 63%. Other key findings that we have found is that majority of C-section are emergency, especially in low resource settings, as Ejiofor mentioned previously. It is also likely that due to poor or lack of antenatal care, our cohort is manifesting with preeclampsia and undiagnosed pregnancy-induced hypertension. Our observations show that there's lack of preoperative assessment of patients and inadequate management of intraoperative maternal hypertension, which can potentially have implications on fetal outcome. We also identified several gaps that could be improved in the neuraxial conduct, and also highlight that there's suboptimal team communication and underutilization of the WHO checklist. As Dr. Bishop has mentioned earlier on, there's this, due to lack of resources, there's often post-anesthesia care often is lacking in sub-Saharan Africa, and this takes place in the form of a corridor with no personnel to look after the mothers who's just undergone cesarean section. So taking all our cumulative experience into account, we're now heading towards shifting away from siloed subspecialty training to multidisciplinary team training. As such, in 2017, we have piloted the SAFE operating room in Ethiopia. This course focuses on team communication and teamwork and safe perioperative care. Up to date, we've trained over 200 healthcare providers in Ethiopia, Uganda, and India. Excitingly, the World Federation Society of Anesthesiologists is also teaming up with other organizations other organized obstetric organization to design a safe cesarean birth training and in Kenya and Myanmar, and this is going to happen in 2021. This is taking components in successful courses in both obstetric anesthesia and in obstetrics itself and midwifery care to make a combined multidisciplinary course. We are also focusing more on longitudinal on-site mentorship as a progress for SAFE courses. We are also abridging a SAFE course so that to 1.5 days, and this can be led by local faculty. Other areas we're looking at is helping to implement quality improvement projects locally and also setting up M&M database. So just to summarize, maternal mortality and morbidity remains high in low middle income country. In order for us to provide safe and quality peripartum care, this requires teamwork. And one cannot underestimate the importance of peer support in changing an individual's behavior. Education initiatives as shown, such as SAFE, has far-reaching impact beyond just knowledge and skill acquisition, but also impact on professional networking and advocacy. It is important for us to all realize that a critical mass and multidisciplinary training are needed in order to bring about effective change in the workplace. Thank you.
So thank you, Andrew and Maytinee. And I think it was a great demonstration there of the importance of teamwork, in particular communication, as a driver for change, but also really interesting to see the amount of long-standing difference that can happen from one educational intervention. So thank you very much for joining us. So we've heard today about some of the challenges, but also opportunities where maternal outcomes are concerned, about how we can all work together to help women going through the pains of labour. I think about spinal anaesthesia can be safe, but it needs to be done in a context-specific way and based on your local evidence and guidance. How it requires all team members to work together in order to produce a safe outcome, and that can be improved and get better through training. But I think overall the key themes that we've discussed have really been about having an appropriate and well-trained team, and that team working together effectively in order to produce a safe outcome for our women, and keeping the women at the heart of everything that we do. So thank you very much for joining us. I really hope you enjoy the rest of your Congress. Thank you.